You're on mute, Boyd. I don't know if you're aware.
Thanks. Thanks, David. First today. Nathan, we're good to go?
Yep, all good to go.
Maternity, agus Falcha. Good morning and welcome. Welcome to all board members and to members of the public and the press accessing the meeting virtually today. I'd like to notify you that the meeting is being recorded for future upload to our web, and to remind board members and participants to use the show of hands facility to speak at the meeting rather than the chat function. Over to Nathan for the apologies.
Thank you, Chair. With apologies from Brian Williams, Elspeth Caithness, Muriel Coburn, Ruth Daly, Jean Boardman and Philip McRae.
Thanks, Nathan. And I should say that Ruth has suffered a family bereavement. Her father passed away on Sunday, and I'm sure you'd want as a board to extend your condolences to Ruth at this very sad time for the family. Declarations of conflicts of interest. Are there any declarations? Alistair?
Yes, thank you, Boyd. Good morning, everyone. I considered making a declaration of interest in my capacity as a connection through being a Highland councillor. However, having looked at the agenda before us today and my connection to the items on the agenda, I consider my connection to be too remote to make that declaration. Thank you.
Thanks, Alistair. Any further declarations? If not, can we move on to item 3, the minute of the meeting of previous meetings, in fact, of 31st May and 28th June, and an action plan follows on from that as well. So if we can look at the first one, the 31st of May, the minutes, can I just ask if there are any points of accuracy rather than go through them page by page? Are there any points of accuracy that anybody wishes to raise at this juncture? Nope. And likewise with the meeting of the 28th of June. Special meeting. Are there any points of accuracy or amendment? I don't see any hands, so take it that both minutes are approved. And are there any matters arising that anybody wishes to raise from either of these minutes? If not, can we look at the action plan, which was added a couple of days ago, I think. So it's in the papers, but just in case you haven't seen it, there are 3 pages in the action plan. Nathan, do you want to say anything particular about the action plan?
No, nothing in particular. It was just a few notes from the last meeting to just kind of keep track of things in terms of when we'll bring it back to the board. So it's fairly straightforward unless anyone has any queries or amendments that need to be made.
Yes, I was going to ask for any additions to the text, any changes, any updates. A couple of people wanted to come in, Anne, followed by Fiona.
Thanks, Boyd. So I've now managed to join on the computer, so rather than my phone, thank goodness. So I just wanted to suggest that the first item on the action plan perhaps be refreshed slightly. I think it's clear that we're not going to know sufficient about the National Care Service proposals to make a judgment about the risks and opportunities until probably towards the end of the year. So I think how it's currently worded is perhaps could do with a bit of updating to accord with the current timetable for that. Thanks.
Pam, did you want to come in on that point?
No, actually, no. I was just late in putting my hand up, sorry.
Okay, so I think we can look at that after the meeting and change the deadline of December 21, which is out of date in any case. Might be that we have some information by December 2022. Fiona.
Yeah, and it was just to draw to colleagues' attention that although we're proposing to close the second action around the wellbeing strategy, that was for a similar reason, in that having now integrated the wellbeing approach into the Together We Care strategy, we are continuing to work on this, but there's a new action at the bottom of the action plan, and we'll be giving regular updates on progress with that. But it was just to draw that to people's attention in case they saw us closing that action and weren't sure if we'd done anything around it.
Thanks, Fiona.
That seemed to work my mouse this morning, sorry. A couple from me. The item from my last Chief Exec's report around the strategy and the timeline relating to the strategy. So we had the strategy at our board development session and this month in draft, as was anticipated. And we will be looking to bring that forward for approval to the September board meeting as we do the refinement and final touches to that, and an associated overarching document relating to our annual delivery plan. So we will bring that back to the September meeting, but just to assure the board that that is on track, and we are in those final stages of refinement and language, etc. The second item on the action log for me is just to note that the Gaelic language plan, we got notification back that the monitoring report was approved by Bord na Gaelic, so that's good news too. So that's complete.
Thanks, Pam. Any further points on the action plan? If not, can we move on to your own report, Pam, and an update on issues arising?
You've got a few things to go through this morning, and I might just stop after each item in case there's any questions. That might be the easiest way to do it, and I will bring Boyd Peters in relation to the first item once I've said a few words. So I'll start off with service pressures, just to pay tribute to the ongoing service pressures that we're experiencing right across the health and care system. Predominantly affected by the most recent COVID wave, and of course we're not out of the woods there yet, albeit it may feel normal out in society. We continue to be challenged by the various things that we have to do in order to keep people safe within our health environments and social care environments. So we have that challenge goes on for us. We of course have also got sickness and absence that gets affected by people developing COVID, and that has had an impact on an already challenged position in terms of staffing. So just to highlight that those pressures continue, and for our staff, and particularly in the hospital setting, but not only. So everywhere is challenged and under pressure, but we have noticed an increased pressure in our hospital systems, our acute hospital systems, where it's really quite relentless for the staff there in terms of the day-to-day management of the volume that's coming through the door, and of course not just the volume, the nature of people presenting with who are more unwell than we've traditionally found as a consistent theme in the past. We have had, as you know, as a board, concerns raised by our frontline staff about the ongoing sustained position and how difficult that is for them, and we are absolutely listening to that. As exec team, we've been out and about quite a bit in the last few months, and certainly in certain quarters more so in the last few weeks. I myself spent an evening in A&E in Raigmore, and it was very evident there just how busy that environment is, and a big thank you to the team for exposing me to all of that and how professional and buoyant they actually were in a space that's extremely challenging. And I know that's the same throughout the hospital, the rest of the hospital, and indeed the rest of the system. So when we've been out in the community as well, I spent a whole day in Fort William, and again, similar challenges being raised right across the system as to how you staff and respond appropriately. So we're very aware and hearing the difficulties for our staff and looking at how we can take that forward in a different way. And I'll come to that in a minute, but I was going to hand over just to Boyd Peters from a quality assurance and clinical governance perspective. I think it's important to hear from our medical director in this space, given the level of a challenge that we're experiencing. So Boyd, if I can hand to you for a minute.
Thanks, Pam, and thanks, Chair. First of all, we've been very aware for some time of the extra pressures in the system. We have had COVID, and we continue to have waves of COVID, and that's against the backdrop of a system that was already running always at a high level of activity and occupancy. Clinical colleagues have been raising concerns. They see the system is running very hot, as it's known technically, and it doesn't seem to have let-ups, and their concerns are about what they have to do in the clinical world and with the challenges that they try to meet day to day, and also, as described, with some of the issues like staff shortages and recruitment challenges that occur. And at the same time, they worry about the safety and quality of their services as they try to balance all of these competing issues. For us in the board, it's valuable to get feedback and to have what we were aware of confirmed by our local clinicians, and to understand what the local perspective is. I think everybody knows that there's no silver bullet. This is the type of pressure that's existing right across the whole country. It's well reported, but nevertheless, it's happening and it's real, and it's here in our frontline services, both in the community and most particularly in the hospitals. I would emphasise that we need to work together, and especially with a close eye on safety and on clinical governance, so the making sure that things are as good as they can possibly be, but understanding that we carry different risks, and that may affect ultimately outcomes for the whole of the health service in the country and here. I think the greatest challenge for clinicians is how they are trying to balance the acute illness management, people who suddenly are unwell with serious illness or who need to be looked at urgently to decide if it is or isn't a serious illness. And at the same time, where doors are opening up to try and catch up with the planned procedures, with the operations and the investigations that happen at the other end of the system. And running all of these together that is one of the greatest challenges. And we need to acknowledge that that's not easy, and that we will have to continue trying to do that. There have been announcements about what is expected or what we are aiming for, but I know that clinical colleagues are currently finding it hard just to keep things going, and so these additional challenges are very real to them. I think with that, like Pam, I will be getting out and about and visiting. I've been to Raigmore several times lately, and next week I'm visiting the hospitals in Oban and Fort William as part of my round of going to clinical sites. It's very important that the board is aware today of these ongoing challenges, which we have referenced before, but also to understand that this looks like it will be the pattern for some time to come as the pandemic waves continue with a new variant tending to cause a wave every couple of months. With that, I'll pass back to Pam.
So I think we've described the problem well on several occasions now, but I guess the really important aspect is, what we're doing about it and how we're supporting these staff. So what we are, as you'll be aware, the Unscheduled National Collaborative was launched in June, and we have been doing a review of our unscheduled care programme in the context of that collaborative launch. And I believe that programme board sits today and will be reviewing the output from that and what the kind of key focus is going to be for us going forward to try and, one, address as much as we can that's within our gift this side of winter, which is, looming. And then alongside that, looking at some of the longer term shifts and changes through our strategy and ADP that will maybe bring about a more sustainable cross-system approach to managing urgent and unplanned care. So we aren't sitting just saying this is all too difficult, there's nothing we can do, albeit, as Boyd said, staff in the front line alongside ourselves know that there are no easy answers. It's incumbent upon us as leaders to try and drive forward the change and to support these staff in the right place and do everything that we can to make things better, as well as support their well-being. So that is in hand, and we will be looking for a communication to come out from that programme board that sets that scene for staff, and then the plan is that there will be significant engagement, and that will have to be quite creative in terms of engagement because staff are busy, so they're not easily released to do the kind of traditional engagement that we would do, but we will be engaging significantly in the coming weeks with staff to prepare for winter, as well as looking at that longer term shift and change that we can perhaps adopt, as well as looking outwards and learning from others. In terms of the public, I think we do need the public to think about how they use our services. We absolutely want people who require emergency and urgent serious illness to be addressed to come to our hospital front doors and to be treated in the right way by the right people quickly and effectively. What we would want, though, also is for those people who can sometimes turn up at our A&Es to really consider whether that's necessary or whether they can go to the pharmacist, the general practitioner, if it's not an urgent same-day requirement, that they can use other services appropriately, use 111 for advice, and allow our emergency services to deal with emergency cases and not be having to be distracted by less urgent cases that perhaps could be dealt with by another professional within our system. So I think that is a plea to the public to really consider whether A&E is the right place for you to go, and to look at the other options available within our communities to support people when they need help. So we're not asking people not to come, but we're asking people to think about where they come to and how urgent is their requirement in that context. So I hope that's helpful. I'll stop there, and I'm happy if there's any questions on that or any points any board members wish to make, I'm happy to take them at this point.
Thanks, Pam. Alex.
Yeah, thanks. Yeah, thanks for that, Pam, and you, Boyd. In terms of staff meeting the challenge, what are we doing in terms of leave? Obviously, staff need leave. They've got to get rest and relaxation, especially coming up to the winter. Are we in a position where we're cancelling people's leave, we're forced to cancel people's leave, or we're reducing the amount of leave they've got? What's the situation, Pam? Thanks.
Yeah, I think it'd be fair to say it will be a mixed bag. We are certainly not proactively trying to cancel people's leave. We are encouraging people to take their leave. That, of course, as you say, that gives us another challenge because we've got the staffing issues that we have. So the summer holidays does make it a whole lot more difficult for us, but we are trying very hard to get staff to take their leave because you do need your rest. I think there are a whole host of things going on where staff may come back and do additional shifts even when they're on leave. So, and there is also out there opportunities for staff to work for other agencies and etc. So we don't have a lot of control over that, but we would be actively encouraging staff to still take their leave and trying to manage through that, because you just stack up another problem. So we just need to navigate that sensitively and carefully, and I think we are. But there's no doubt when it comes to peak leave season, it's incredibly difficult for us.
Jerry.
Thank you, Boyd. Thank you to Pam and Boyd. Just a quick question, I think, maybe for Pam and Boyd, in terms of the alternative presentation areas where patients may go to instead of presenting at A&E. Do we have any evidence yet as to why people are continuing to present to A&E when perhaps there are alternatives? Is that an issue of education, or is it an issue of capacity elsewhere in the system that they've tried and are getting no success there? Do we understand that, Pam? Because I know we see the message nationally in terms of don't go to A&E unless it's life-threatening, but I'm getting the sense that people are still continuing to present to A&E, and I just wondered if we have any understanding of why that should be the case. Thank you.
Yeah, I suppose we have kind of anecdotes from people where they may say that accessing other services is difficult, but we probably don't have the evidence to know if that's actually the case. And I think you know, it's very convenient. I think that's probably the top line one that I think generally most people have seen, is it is a very convenient way to access if you are worried, and of course we understand that, but I think it is just continuing to try and get that message out that there are other ways to access healthcare, and actually that, you know, if you use 111 and have the conversation about how urgent your care actually is, it may be that it's okay for you to hang on 24 hours and wait till Monday till the GP practice is open and be attended to in the way that you know that system is set up to do. I don't know, Boyd, if you've got anything you want to add to that, but that would be my assessment.
Yeah, I think it's a very large issue, and it's not specifically just about ED attendances, although that is an element of it. So what is seen right around the country and what is happening in the Highlands is that generally length of stay is longer than it was, and that isn't just the immediate front door of community into hospital through the various routes people can come, like ambulance out of our service or just driving themselves to a facility. It's the next bit, and it's the journey through the hospital. Some of that's linked to how we manage patients now with the whole sort of COVID approach. There's still some testing rules which may change. I understand that there are national discussions between the four nations about how that might change. That may help things, may help the system be more efficient, but it's complex. And I think probably to answer your question, which is a very good question, properly, we would have to really get under the skin of it, look at the detail, pull out the data. I think some of that's being done already, and I think your question certainly triggers me to think about how we might try to make that more understandable and explainable for yourself and for the public, and also for us to understand why our system is running the way it does. The other point to remember is that this is not a sudden crisis and a cancel leave and it'll all be, you know, managed. We're seeing a series of waves every 6 to 12 weeks of COVID. You know, we had one, I think it was in March, April. We've got another one now. It's a flatter peak. It's taking longer to pass. The next one will come along probably September, October. This will continue, and pandemics do this, and they do it for a number of years after the first big waves have occurred, and we are in that phase. So we will have a continual marathon type situation rather than a sprint and then it's all finished and we can catch our breath. And that is the really important message here, is that we will continue to have these pressures. right into next year and quite possibly the year after at this, by the looks of things.
Thanks, Pam and Boyd. Bert, followed by Alistair.
Thank you, Chair. I just wanted to thank Pam and Boyd for their input this morning in relation to these pressures on the system and for a very candid description of where we are now. I guess I should mention that in my specific role on the board, I have been aware of these frustrations that staff have been experiencing and people who have come forward to me, and of course I have passed these on. But it's very useful and indeed reassuring to know from Pam and from Boyd about their engagement with staff. I've seen it firsthand for myself on my visits to various health settings across the Highlands and indeed in Argyll and Bute about the difficulties that people are facing, and they're coming forward with genuine concerns born out of frustration, born out of sheer tiredness. So thank you, Pam and Boyd, for sharing that with us in a public forum. I think that's important, and it's useful also to know about what is being done locally and nationally to try and deal with this. Thank you.
Thanks, Bert. Alistair.
Yes, thank you. I'd like to endorse what Bert said on the point about the pressure on staff. I think we all know people that work for NHS Highland that are impacted by this and who have given up their time and their leisure time to do it. I just want to return to the A&E scenario, and obviously in my capacity as a councillor, I meet a lot of people, and my take on the A&E situation is that the A&E doors are always open. They never turn anybody away. They're always very caring and considerate when people actually do approach them, and people know that's the safety net. I've also heard that it's from some people it's very difficult to get a GP appointment, especially on a Friday or a weekend. I've also heard anecdotally that there is quite long waiting times for 111 to get back to people, especially after maybe the call's been triaged, and that delay probably reflects the fact that it's not particularly serious in consideration with perhaps some of the other cases that have been dealt with by 111, and then, if you like, the panic or the fear or the uncertainty creeps into the patient or their family, and they say, "Oh, let's just go to A&E." And I envisage that's how probably people end up at A&E, and they get a fabulous service from A&E, and often they don't mind waiting the time at A&E because they feel assured that they're in the building and there's people around. And I don't know, Boyd, if there's anything you can say that, or any thoughts you might have on this that might actually get that assurance over to people so that they're not worried and they're prepared to wait. Because I think it's that not knowing and having to wait that probably causes the pressure. Well, let's just go to A&E. It's only up the road. We can get there in 10 minutes. But I suspect it's probably a combination of those factors which actually add to it. Thank you.
Chair, I'll take that then. I think, it's complex in a lot of detail, perhaps at the board level we don't want to get entirely into, but in general, we find that people are they're accessing the NHS services differently since COVID, and that hasn't reverted back to how it was pre-COVID. And so we're trying to understand that. That's the first message. The second one is that in the Highlands, we probably have a different, we don't do what's known as redirection, where people turn up to A&E, but they may actually be better served elsewhere, or they maybe shouldn't have come to A&E with that particular condition. there are other boards where that will be different, and that there's a firmer redirection. But in the Highlands, people will travel sometimes quite a long distance to a facility, so it is quite difficult to turn them away, even if actually they would be better looked after somewhere else. I would therefore encourage people to ring 24, the service NHS 24, dial 111 and get some advice, look up NHS Inform, and consider what the local services are and how they might make access those, because it may be better to go to somewhere that's 10 or 20 miles away and perhaps have a much shorter wait and be through an appointment so that it's arranged, rather than going to somewhere that could be, you know, 30, 40 miles away in an A&E facility where you just turn up, but you'll be at the back of a long queue. And if there have been some serious issues happening, if they're, you know, seriously ill cases, or the car accidents or whatever else, that queue will be a very long time before it gets to you. And so it is sensible, where you don't have a life-threatening illness or injury, that you do a little bit of that contact in advance, so that you don't have to get stuck in a hospital waiting for ages while lots of other cases go in front of you. So I would make that appeal. There's plenty of information available, and we may, prompted by this discussion, need to rethink putting something else out again to support people, just so they don't waste a long journey and a lot of time queuing when they could have been dealt with in a different way that would have been much quicker for them and perhaps more appropriate for their condition.
Thanks, Boyd. Graham.
Hello, Pam. You've reminded us that that this is a national problem, and Boyd was also just reminding us that this looks likely to continue. Could you maybe tell us about what work is being done across the country, and how health boards are coordinating with government about what looks like an issue that's going to be around for some time to come? Thanks.
So nationally, the Unscheduled Care Collaborative was launched in June, and all boards had people participating in that launch and event that sets out a set of high impact interventions that you need to assess your own board against, in terms of what are the right things to do locally that might make a difference. And those are things that we have come to rely on in the past, and they do have some effect to some degree, and we are looking diligently at which of those, I think there's 10, which of those we would select, and that's what's happening today. That plan's being refined today. So each board will look at that through the lens of their population and what the presentations and needs are of that population. For us, of course, we have to look at that through that lens, but also the geography. So 40% of Scotland and 36 islands means it's quite a different response, and some of the things that would work in an urban area just won't work for us. So that is what the Unscheduled Care Programme Board is doing, but all boards are part of that collaborative, and all boards are reviewing and realigning their plans in that context. And all boards are looking at that also with an eye to winter and the future waves of COVID that are anticipated, just as Boyd's set out. So we're all engaged in the same way. What I would say is that at a national level, in terms of our discussions and in terms of the problems that we've described, it's a very repetitive, consistent story. And the challenge around what is the right recipe to get us back into shape is still very live and still a very live debate. So we know there are some basics that we can do, and that if we do them diligently, they'll make a bit of a difference. But I think as Boyd set out, the kind of shape of things isn't the same. We're definitely in an amplified. Things are definitely much more amplified and difficult in comparison to how they were pre-pandemic. But we remember we had some of these problems pre-pandemic. So they've become greater over that time. So we also are charged with trying to think, what are the different things that we can do? How does digital transform how we manage this? You know, we've used digital a lot through the pandemic in terms of remote consultation. Have we optimised that? Have we optimised remote monitoring? What I mean by that is people reporting in through, you know, your watches that monitor your health. Are we using these ways of understanding where people are at and therefore being able to intervene? And I think we still have quite a way to go in that. So there's the innovation space as well as some of the, I guess, bedrock interventions that we need to do diligently that hopefully will help us. But as long as we've got the process of infection control at the level we have, and having to manage that safety aspect, it slows everything down as well. So we have got a few different dynamics that we didn't have pre-pandemic. And of course, we're still in a pandemic, which is often forgotten.
Thanks, Pam. Joanne.
Thanks, Boyd. I just wondered if you had plans to raise the communication plans that you have in place around this topic, or even to change the message to kind of spread and have maximum impact to the public. Thanks.
Yes, we so Ruth has a number of campaigns that will be going forward in terms of communication, but every week we consider what else we can put out to support the local situation, and certainly after today, when the programme boards met, we'll be looking at what those messages need to be and what it is that we're doing. I think Ruth will probably come in and augment a bit of what I've said there. Ruth.
If I can get my camera switched on. Thank you, Pam. Yes, so there is a national campaign, Right Care, Right Place, which is about exactly that, asking people to call 111 and attend the right place for their care. And as Pam says, we do look at the local situation. So we have meetings scheduled around that, and particularly around emergency care, and looking at what we can do that's more immediate in terms of reporting back on the immediate situation, and using that information to look at people's behaviour and the exact messaging that will work best to direct them to the right place for their care. So yes, that's an ongoing campaign.
Oh, you're on mute, Boyd.
It's back to you now, Pam, for the rest of you.
Okay, so just to finish off on that, obviously our staff, what concerns them most and what concerns us all the most is delivering the best care to people. And that's the motives behind the concerns that are raised. So they're the right, it's right that they should be raised with us. And it's right that we should be coming from that place when we're trying to address them. Because I think we're all human, and in those circumstances where you're unwell, you do want to know that you're in confident hands and that you're getting dealt with in a timious and supportive way. And I think I just want to emphasise that whilst I've spoken a lot about the front door, you know, care at home, care homes, our community teams, district nursing, they are all feeling it and all coming up against it. So it presents in different forms. So just not to forget that. Okay, moving on to scheduled care. We've been given a revised set of targets, which I'm sure the board are all aware of. It's been quite public in terms of dealing with urgent and long waits. There's also been a change to reverting back to how we prioritised pre-pandemic, so a move away from the kind of P1 to P4 prioritisation back to urgent and routine, and a focus on long waits. Catherine with her team and with Lorraine have been revising our plans in the context of those targets, and so we do know where we can achieve, and we do know where it's going to be more challenging for us, and we're currently in negotiation with the government team around that. as to where that will land and what support they will give to us. There is also an approach around what's referred to as a reasonable offer. So I guess an example of that for us might be that we could offer people to go for the Joint Sleep Golden Jubilee, and they may choose to make that journey. I think in terms of how we use our estate and our resources, that reasonable offer has absolutely got to consider what it means for our workforce in terms of them moving around. It's very different if you're moving someone around Glasgow as if you're moving someone around the Highlands, both for our staff and for our patients. So we are working through the interpretation of the ask, and as I say, we have done an assessment of where we believe we're at, and we're in negotiating about how that can be optimised or how the government can support us in being successful in that space, and that will probably come back to you at a later date in terms of how that's progressing through our committees, etc., and perhaps a little bit when we're in the on looking at the performance. I suppose just a couple of headlines that might that are good news. So we have managed to ring fence our day surgery unit again after it having been stood down for some time to a much reduced level, and that has got up and running, and we are supporting that to continue to do so. So that is a good step forward. I think it's also important to say that from our orthopaedic elective programme, that we have seen since the 1st of April to the end of June 436 people for their operations. So there is activity going on there, and we are nudging forward. But of course, that all sits within the context of the wider annual delivery plan and the targets and the I suppose the run rate. So that's the rate of how many operations we are aiming to do in a week and how we are achieving that. So we had set a target earlier, which we were struggling a little bit to achieve, and those have been revised, and we're working again with the Scottish Government team about any additional independent sector or additional support that we can get to get everything optimised best we can. And of course, there is a real relationship between how well we do our urgent and unscheduled care versus our scheduled care in terms of bed availability for those who have had surgery and need to be cared for. So a huge amount of work going on in that space. I think additional to that, we are also at that point where thankfully, I can say today that the National Treatment Centre remains on target for the report that you had last board meeting, and you'll get another formal report in September. And of course, now the work is to understand how the activity there for the Highland component of that, because remember, a percentage of the National Treatment Centre activity goes out to all other boards to use as part of that network. But for the activity that is for Highland patients, we will be looking at how that will impact our plans, and therefore in ophthalmology and in orthopaedics, how that will change the current plan and how it will improve, hopefully, the current position. That's what we're absolutely about. And again, we should be able to come forward in the near future to be into the autumn with our definitive plans and commitments in terms of how that will pan out. But a really important piece of planning, and really important to see what value that's going to add, how that's going to help us with our backlog, as well as what that does then to how we work now without the NTC, and therefore what that capacity starts to look like. So interesting times and a lot to come forward on, but I just wanted to just pass on that what is starting to be a more improved position. However, we do have quite a way to go.
Thanks, Pam. Any further questions for Pam on these points? Alex.
Yeah, thanks, Brett. Pam, on the revised targets, and we had a bit of a chat about that the session last week. Are we getting additional funding? Is there any additional funding? Or is it something we can bid for to help us achieve these targets? And are we actually being, truthful is not the right word, are we being realistic about how some of these are achievable or aren't achievable, and get that to the Scottish Government now, rather than saying, well, we'll wait, 6 months and go, oh my God, we're not going to make the target, whereas we know now we're not going to meet the target. Thanks.
Yeah, so the assessment that Catherine has done, I'll give her just a minute to come in, has very much set out where we believe we can and where we believe we will struggle, and where, so if you take it on a red, amber, green, we've assessed it against a risk profile, and we have set out what it would require in terms of support from Scottish Government, either by additional investment or working with us to be able to achieve the targets as set out. And I'll give Catherine just a quick word on that, because she's been doing all the work.
Yeah, thanks, Pam. And the hopefully you can hear me okay. The targets are significantly challenging, but what I can reassure on is for the first of the targets, which is a 2-year wait for outpatients in most specialities by the end of August 2022, we're confident that we will deliver on that as a health board. So that's really good news for us. The second target is in relation to 18 months for outpatients in most specialties by the end of December 2022. And again, we're reasonably confident that we will make that target, and we're working through that. When we go into some of the other targets, which is 1 year for outpatients in most specialities by the end of March 2023, 18 months waits for inpatient and day cases by the end of 23, and 1 year for inpatient and day cases by the majority of specialties by September 2024. The dates for those are further away, so we're RAG rating them as a status of amber at the moment, and we're working through with the clinical teams on that and with Scottish Government as well. The final target that they've set us, which is really challenging for us, is 2-year waits for inpatient and day cases in the majority of specialties by September 2022, which gives us 2 months to address a significant backlog in many specialties. That is an area that we're really challenged on, and particularly in relation to orthopaedics. So we are working with the Scottish Government very closely. There is a meeting that has been established that meets weekly that I attend, and that is looking at where across Scotland are health boards most challenged in terms of delivering these targets, and how could capacity be shared across either the northern region or indeed across Scotland to help all health boards achieve these targets. So we're working very, very closely. We have accessed additional capacity at the Golden Jubilee already to support delivering orthopaedic joint operations, because we know we're really challenged around that, and we continue to work in that space.
Thanks, Catherine. Anne.
So what I was wondering, Catherine, in your planning assumptions and from our own existing experience of our public and the efforts that we have been making to operate 4 hospitals, 1 site, for example, will achieving the targets require our public to be more flexible in terms of how willing they are to travel to receive their operation? And if so, how are we going to communicate that issue to the public? And I also wondered whether we are increasing any efforts to support those patients with long waits, while they are waiting to manage their conditions. Thank you.
Thanks, and absolutely, that's absolutely critical. So we're looking at all of our capacity across the specialty areas with a view to supporting those that are longest waiting, and also those that are urgent for urgent operation and urgent prioritisation. So that does require a level of flexibility to access some of the capacity, particularly that we have, that's prime capacity in the RGHs. and also in going to access capacity out with the Health Board area at the Golden Jubilee. We've written out to our patient group and asked them if they were, happy to engage in going to other areas. So we're checking that out with our patients, writing out to them. And so far we've had a quarter of our patients have written back positively and said that yes, they would be happy to be flexible with where they are seen. So we are also looking at, ensuring that we support them with accommodation, with travel and with other things to help them to access service as much as possible. In terms of what are we doing to support our patients whilst they're waiting, we have a clinical review of patients on the waiting list, and should we feel that people through those processes require additional support, then we are reviewing them to assess what that additional support might be, and actually either signposting them to additional other services within the Health Board, or indeed, bringing their clinical interventions forward on the waiting times because the clinical condition has changed.
I think we probably still have a bit to do on the waiting well aspect and the kind of messaging to the public, and that is definitely something that piece of work that's underway, and we'll look to bring forward maybe a briefing on where we're at with that, and because that is a piece that hasn't traditionally been there, and but definitely something we could be doing with people to advise them on how they can keep themselves fit and well, how to manage pain, and support them while they wait. And there's an important aspect to that. If we can work with the public to support that wellness aspect whilst you're waiting, then you are more fit and likely to get a better recovery from your surgery. So it's really an important piece. Now, there'll be elements of that going on anyway, because general practice will already have these kind of conversations with their patients. But I think we could improve on our messaging at a local level within our communities on that.
Could I just ask, Catherine, so you said that around a quarter of the people we wrote to were positive about being willing to be flexible. Is that considerably more than are being flexible at the moment? I was wondering, does that show that we have quite a lot of room for manoeuvre there, or is that pretty much in line with our current experience? Thanks.
Yeah, thanks, Anne. I think we haven't been as explicit previously and asked people to be expressly advising us of their acceptance of going to an alternative location. The reason we want to engage with our patients in this way is we absolutely don't want to drop any capacity. So if there are people that feel they would be comfortable to go and access capacity in different areas, then we want them to have an opportunity to go and access that. So it's very much about trying to ensure that we don't waste any capacity at all, and we work with our public on that. We've definitely got work to continue to do in this space, Anne, in terms of our communication, in terms of our support to our families and people waiting to access service. But this is our first step in learning. How do we do that well? What do we need to put in place to support people? And what we will be doing is looking at the other 75% and trying to understand from them what would encourage them to take up. But this is a good first start for us to be able to make good use of the capacity and be confident that people will take that offer up.
Yeah, so I think just to add, this is very much about informed choice. So ensuring that people understand that we can support them in that way and that it's their choice. This is working with people, not making decisions for people. And so I think that result gives us an insight. And as Catherine says, there's more work to be done, but the people will make the right choice for them, and we need to make sure they're getting the opportunity to make that choice would be my observation. Okay. I've got 2 things to go, Boyd. I promise I'll be quick. The next 2 are quick.
Okay.
So maternity, we will be bringing the business case to the September board meeting. We've still got quite a bit of work to do this month, but we are confident we can bring that forward in September, and all that work continues with our teams, etc. So we will come back to that. And the last piece is really important and really significant piece of news for us. Our initial agreement for Lochaber was approved nationally, and we now move to outline business case. The news and the official formal letter telling us that that was the case came through on the 4th of July, and we will work obviously with the community in and around that. Great news for the local people there. There is a caveat around construction timescales. However, we have a lot of work to do in getting through an outline business case, so it isn't probably of such a big concern to us at this point. I think, having been down with the teams there on the Friday before that, they were very keen to hear news like this. They hope that that will help with recruitment because it gives certainty to the locality. So a really significant step and really important for the board, and the opportunity for yet another fantastic facility in the future within our broad estate for hospital care. And that's me.
Thanks, Pam. That's a really significant development, and it's not a case of a replacement for the Belford Hospital. It's a redesign of services across the community in Lochaber, and a real opportunity to come up with new solutions and new ways of delivering the services. So can we move on then now to first of 2 reports by Tim on public health, first on COVID, and I believe you've got a presentation, Tim.
Thank you, Chair. Yes, I have one that is in the papers, but I will endeavour to share my screen, and I hope that everyone can is able to see that. Great. Okay. As has already been said earlier on in the board meeting, COVID is certainly still with us, and it's important to remember that as it to some extent slips out of the headlines. One of the challenges that we've got in terms of managing COVID is the lack of routine testing, but there are other ways to estimate or certainly get a good idea of the level of COVID within the community. There we go. And one of these is the UK-wide survey undertaken by the Office for National Statistics, which is based on sampling of a representative group of the population across the UK, and then testing for COVID. And the chart here shows the results from the ONS survey for Scotland, demonstrating that there's certainly been a rise in COVID over the last few months. It does seem to be levelling off, but what's interesting is that we're up to about sort of 6%, 7%, around 1 in 15 of the population, which is very high, and is almost as high as it was in the earlier Omicron wave. Oops, sorry. Another way to look at the COVID is wastewater, sewage water, where we can test for COVID, and that gives another objective way of judging the level of COVID in the population. It's still somewhat experimental, but this again shows, if you look at the the two lines towards July to the right hand of the chart, it certainly shows an increase in the level of COVID in the population. As I said, we have a challenge in terms of what's happening with testing, in that community testing has largely stopped. There is testing still going on, and this shows the results of that. Just to note that the scales on the left are different. So the actual numbers of positives in Highland are HSCP are higher than in Argyll and Bute, although it doesn't quite look like that from the from what's presented. These test results come from staff, come from patients, comes from residents in care homes or other ways in which people get tested, and it's a little bit difficult to interpret, but they certainly show that COVID is still with us. Hospital occupancy again demonstrates level of COVID. This is for NHS Highland, showing, I suppose, a fairly stable number of people admitted into hospital with who've tested positive for COVID. Somewhere around a quarter or a third of people are in hospital because of COVID, and the rest, for the rest of people, that COVID is a finding not related to their admission. It may make them more sick, but it's not the cause of their admission. In Scotland as a whole, there have been a bit of a higher peak in June and July. So there is a risk that we tend to get things a little bit later in Highland. So there's a risk that we may still see an increase in cases, and the impact is partly through people being ill from COVID and needing the care and treatment for that, but it's also the infection control precautions, as Boyd Peters has talked about earlier, and also, of course, staff sickness. Another thing that we should remember is that COVID is not a benign disease. While there have been very major advances in the protection for the population, with particularly vaccination, but also other treatments and other measures of control, sadly there are still quite a few people locally, nationally, internationally dying from COVID, and perhaps it's slightly surprising to see the numbers over the last few months are potentially more than we might think. So this chart shows across NHS Highland the number of people dying where COVID has been included on the death certificate. So this may be a cause of death, or it may be something that has contributed to someone's death, perhaps by making the underlying condition worse. So you can see that there are clearly three peaks of the first peak right at the start of COVID in the middle of 2020, then around the winter of 2020, just as vaccination started, we are also seeing the wave of Delta. That's when Delta came in, and then we have the wave that we're currently hopefully towards the tail end of with Omicron. But there are different strains of Omicron, and you can see that that's had very significant effects. The slide I've put up here on issues is identical to the slide that I put up at the May board, and that's not accidental. It's really because the issues that we were facing in May are really continuing with us now. So I won't go through them one by one, but it's important to recognise that what we have is a continuation of a whole range of issues that aren't going away. They may be getting somewhat less as we get more experience, as vaccination coverage increases, but we will be facing COVID for quite some time to come, and also complicated by other issues such as flu. We do have some successes. Our vaccination efforts, certainly early on, and around, I suppose, particularly around the spring of 2021 were really good, and we've continued with the vaccination efforts. And this graph shows our latest performance for the spring booster. Clearly, the spring booster, spring's gone, and the booster campaign has really just in terms of mopping up, but we're just shy of 90% in people over 75-year-olds, a bit higher in Argyll and Bute, a little bit lower in Highland HSCP, and that's roughly in line with the rest of Scotland. And for some groups, such as care home residents, that vaccination is higher than Scotland. So that's the end of the presentation. We've got many challenges to come, particularly over ensuring good vaccination coverage over autumn, which links with the next paper, but I'm happy to take any questions from members.
Any questions for Tim on COVID? Alex, followed by Sarah.
Thanks, Chair. Thanks for that, Tim. What's the feeling about the amount of tourists that are going to come in? I mean, as always, every summer we get a big influx of tourists from all over from the UK and from all over Europe and the world. Is there a risk of a new variant coming in from Europe? What kind of impact do you think the numbers will be from our UK or the rest of the UK tourists coming in and potentially bringing more COVID in with them? Is that something that you've looked at? Have we got experience of that from past years? Thanks.
Thanks. Just on the experience first, we've certainly got experience of tourists and COVID. We've had some outbreaks that have been linked to or really involving tourists. We have cruise ships which have cases of COVID. We have coach tours with cases of COVID. I think most people who come, or a large proportion of the people who come as tourists to the area are engaged in outdoor activity, which will mitigate the risk. So while we will see episodes and need to work on dealing with those, and tourists can become sick and need care, I think that is probably a larger risk than actually spreading around in the population. We need to guard against that and look at good practice. But with most people being outside, it's a little bit less of a risk. We will certainly, I mean, by the very nature of any variants do come in from outside with either our local residents coming back or tourists coming in. There's got to be some reason for variants to come in. I am not particularly concerned around variants coming in with tourists or coming in from Europe. The variants that we've seen may well come in from other parts of the world. Some of the variants have come in from South Africa that we're experiencing at the moment. There's a variant in India at the moment that may be the cause of a future wave. So there are things that we need to guard against, but I don't think on balance that there is much in terms of specific action, more than we're doing at the moment and more than general advice and information that would have a hugely positive net effect.
Thanks, Tim. Sarah.
Thank you. So some of this might come into the next item around vaccination, but I was interested to know if either locally or nationally there's been any work to look at the outcomes for people with COVID or long COVID who may experience health inequalities, and if there's any kind of approach that's being looked at, again, either nationally or locally, to try and address that. And I'm thinking about kind of outcomes in terms of, you know, how how they come through the disease itself, but also perhaps barriers around vaccination, which might come into the next item. Thank you.
Yeah, I mean, there's been a reasonable amount of work in terms of health inequalities and COVID. It's generally been around some socioeconomic inequalities, and particularly around ethnic minority inequalities in terms of vaccine uptake, but also around vulnerability to COVID. There's been some work done locally on inequalities and isolation, working with the island boards and looking at access to healthcare. In terms of long COVID, there hasn't been much work done specifically that I'm aware of, specifically on inequalities. I think that will come as we become more conscious around the numbers and the impact of long COVID, and we've got work going on within the board looking at how to develop services for long COVID. But I suppose from an inequalities point of view, what we've tried to do particularly is look at access for equality of vaccination, which is quite a challenge, linking up with all the other vaccination issues. It's perhaps easier on some of the island communities where we've been able to do a vaccination option appraisal and continue with services there. Elsewhere, we've needed to adapt to models. So we're very conscious of the issues of inequalities, COVID, long COVID, and vaccination, but there's still a lot more work to do. And also, as put on one of the slides, of the social mitigation, which is, I suppose, fundamentally around inequalities. A lot of the inequalities resulting from COVID regarding income, employment, linked up with other issues of rising prices. So it's something, I suppose, it's core to the work that we're doing, but there are specific areas around COVID inequalities where we still need to do more.
Yeah, thank you, Tim. I don't see any further hands up at this point, so we note that Tim's report on the COVID update and move on to the vaccination strategy. Tim, can you speak to the strategy?
Thank you very much. Just give me a second to get the papers up. Okay. Board members will recall that at the last board meeting, I presented a paper on the development of vaccination strategy, including COVID and flu vaccination and the vaccination transformation programme. Certainly, in terms of vaccination transformation, the VTP, we have been behind other boards in implementation. There have been quite a lot of challenges. Our models for implementation were still, or some of the models are still being developed at the time of the last board meeting. Board members felt that it wasn't appropriate to have moderate assurance, but felt that only limited assurance could be taken from the previous board paper, and requested that an update paper be brought to the board, to this board meeting, and that's the origin of the paper which is presented today. We've been able to make considerable progress in development of both flu and COVID vaccination implementation and the VTP. Some of the progress, particularly in the Highland HSCP area, has been confirmed very recently, and some of that the details of that will be able to present it in a minute verbally by, I'll talk a little bit about that, and Louise can potentially talk about some further details. But to highlight the progress that's been made across the board, we've got the central support services have been I suppose strengthened, and permanent appointments have been made on things like pharmacy and e-health and performance. Argyll and Bute have been recruiting to their service and their model, which is joint with the community treatment and care service, and that's becoming much better established. Within North Highland, the delivery model has now been agreed. The way it has is being set up is a combination of locality-based services and central services. It has a central scheduling procedures, but uses integrated team-based general adult nurses to provide vaccination administration, and the centralised team for preschool vaccination. There's also centralised operational planning and the best value approach has been used and will be used across the different localities, with the potential of third party people being brought in to administer the vaccines. Given our geographical circumstances and finances available, that's also been quite a challenge to look to be able to deliver the vaccination programme within NRAC share of allocation. We've still got a little way to go to manage to get the whole programme delivered under the NRAC allocation, but there's been a large amount of work has been done, and we've reduced the gap from originally around, I think, getting on for £3 million down to just over £300,000. So further work will need to be done over the next few months in order to reduce that gap still further, in line with the other work that's been done across the board for to get financial balance. That still remains a risk that board members need to be aware of, and there's also the other principal risk is around staffing and recruitment, because it's clearly a large new service, which is also geographically spread out, so that does remain a risk, but the risk will certainly be very highly mitigated by the locality approach, and also by using existing staff in terms of delivery. So I feel that the programme and for delivery, the risks remain, but I feel that we're able now to offer what I hope board members will accept as moderate assurance. Before questions, I don't know whether Louise is wanting to say anything more around the Highland HSCP model, which is probably one of the areas where board members were less assured at the last meeting.
Yes, thanks, Tim. Absolutely, we're in much more of a clear picture about where we're going with the model, and there's a greater understanding and buy-in from services. We've got recruitment already taken place across various different areas to cover the established team, and we are recruiting for bank for the autumn vaccination, because we need that flex model of substantive staff in post, but also when we've got peaks and troughs, we'll be using that bank cover. So we've got all of that in train. We're also working closely with other areas, so community pharmacy and SAS are part of our model for that flex too. And certainly we were also doing some test of change. For example, in the northwest, we are now providing preschool vaccinations instead of the GPs, because that was an ask of those GP practices, and it's been a really good experience for us. It's been positive about where that model goes in the future, because one of our slight vulnerabilities and concerns is around that childhood vaccination, preschool children, that we haven't necessarily in the board yet got the expertise across the board for. So that is one of the areas that we're having to really plan ahead. We're also working with the Highland Council in relation to the existing school age services that are provided within their area. So there's a number of pieces of work. There's the autumn vaccination programme that we're actively recruiting, and then there's the medium term, if you like, getting us to the place where we've got all the vaccinations in train. Travel vaccinations is resolved around community pharmacy, etc. So it's an improving picture, absolutely, from as Tim has described. The vulnerabilities, as with many of the things we're doing, are around that recruitment. So we are looking at what other contingencies need to be put in place if we struggle in some of our areas, because we have obvious hotspots that are more of a challenge for recruitment than others. So we're looking at all of those potentials too.
Yeah, thank you, Louise and Tim, and open it now to questions. Graham.
Thanks, Tim. Tim, this is maybe a comment as much as a question. But having spoken to some members of vaccination teams as they're out and about, some of the vaccination teams are travelling considerable distances every day, just to deliver vaccinations. So of course that we can all get them locally. But I'm guessing that across the whole area, both Argyll and the Highlands, the amount of travel that staff are having to do in the delivery of vaccinations is not insubstantial, and therefore the cost and the pressure must be, it must be, I think, quite significant. But I'd be interested, and I know you won't have any facts on this yet, and you're still trying to get these going, but it's certainly something that struck me.
Yeah.
Back on that, Tim?
Yes, thanks. Yes, I mean, travel is a huge is a huge issue. Part of the locality approach is to try and get locality focus, which makes it best for residents to be able to be vaccinated, but also if we can get people who are in the localities to be able to be the vaccinators, then even better. Inevitably, there will be travelling, either from the people doing the vaccinating or the people receiving the vaccinating, and we are aiming for a patient-centred service, resident-centred service. So I think it's inevitable that there will be staff travel, and it makes, we try and minimise it, but it does make it more challenging in terms of money, because we're having a far more spread out and disseminated model than, say, the boards in the Central Belt or more urban areas, who can have one or a small number of very large vaccination centres, and people can then travel into them. The logistics are easier and the costs are lower, and we may be told that a lot of that is taken into account in our NRAC allocation, but it is still a huge challenge to be able to deliver across the enormous geography.
Thank you, Tim. Alex, followed by Anne.
Thanks, Chair. Yeah, a couple of questions for Tim and Louise. Tim, the protection waning, if you like, was one of the reasons why we had these boosters. At the time, beginning, I thought they said 6 months was where they were sort of looking at when people should be revaccinated if they were in this this population that was at risk. I know some people that had vaccinations in February and March that would have been their fourth. Now autumn, I mean, are we actually talking about giving people a fifth vaccination now, because that's 6 months beyond that, or will those people have to wait until this autumn campaign starts, which may be September, October, November? And in terms of the strategy for this autumn campaign, will no GPs be involved at all now? Have we moved completely away from the GPs, particularly up in the Caithness and Sutherland area, where an awful lot of the previous vaccinations were given by GPs? Thanks.
Thanks. Yeah, so to deal with the first one, in terms of people waiting, yes, people will need to wait until the autumn campaign. What we're doing at the moment really is a mopping up exercise to make sure that people both have their fourth dose, those who are entitled to a fourth dose, but also people who are unvaccinated. We're still encouraging them to come forward for their first dose, second dose, third dose. And we've also got some younger members of the population who will need to be vaccinated. Immunity does wane, but it doesn't fall off a cliff. It's not that at 6 months you suddenly become markedly less protected than you were at 5 months. So there's a large amount of protection still there, but we need to try and get the appropriate campaign that actually is effective and works with what vaccine stocks are available nationally, and also works so that people can ideally get flu and COVID vaccinations at the same time. The latest advice from the Joint Committee from Vaccination and Immunisation takes the age down to 50, so it will be a large amount of the population who will be covered, and the aim is also to get that programme finished by early December. I think that will be quite a logistical challenge for us, but the aim is to get everybody protected so that waves of either COVID or flu are most protected against. And I suppose overall it's a balance between what is feasible as an overall vaccination programme and what offers a good degree of protection. So people who have had 4 doses of the vaccine should be quite well protected. I mean, it's a population programme, so doesn't give 100% protection to everybody, but it gives a very good protection to a large proportion of the population. There are also new vaccines coming on stream. We don't know precisely when. We don't know when they'll be licensed and able to be used, but there are some new vaccines that give protection both against the original strain, because it's the original Wuhan strain of the virus that all the vaccines are targeted against at the moment, but they also give cross protection against other strains of COVID. There are new vaccines which are specifically designed to give both protection against the original strain and variant strains. Whether they'll be significantly more effective, we don't know yet, but they'll be coming on later. So that's another weapon in the armoury. In terms of GPs and vaccination, I think I mentioned it in the paper, but again, I want to thank the GPs as well as others for taking part in the vaccination programme, and we're really grateful both for the work that the GPs have done in COVID and flu, both over the year, many years for flu, but recently for COVID, and also in terms of delivering the other vaccinations. We have a largely mixed model at the moment as we implement the VTP, and a lot of the vaccinations are still being delivered by GPs. COVID and flu will essentially be delivered by the board over this autumn. It's difficult to predict and look at local circumstances and to say exactly what will happen, so I'm not ruling anything out. And we've made use of lots of different resources, including GPs, and they've been come to help when needed. But principally, we will be continuing with board vaccination for COVID and flu for the autumn programme. GPs will be continuing in many parts of NHS Highland to deliver other routine vaccinations as we carry on with the transfer over for the rest of the financial year, and then we'll be looking at comprehensive board delivered services for all vaccinations within the new financial year. There are, of course, areas that have had options appraisals, which is mainly Argyll and Bute Islands, where GP delivery has been judged as the most appropriate way for routine vaccinations and for COVID and flu vaccinations, and that will continue there, and all done in line with Scottish Government policy.
Thank you, Tim. Anne.
Thanks, Boyd. So my first question is whether the extension of the age limit for the autumn booster campaign has a significant impact on our plans, and if so, how we're addressing that. And secondly, specifically for, I guess, for Louise, in relation to the plans for the Highland Council area, are you able to say whether the locality plans will mean that we will be offering fewer, the same, or more locations for people to obtain their vaccination from? Thanks.
If I answer the first question, the answer to your question is yes. It does have the change in age clearly has a significant impact, but it's an impact. But our plans have been prepared for both starting 65, starting at 50. So clearly, starting at 50, we need more. And JCVI, until very recently, their provisional advice, I think, have been starting at 65. So that is quite recent. But we have been aware of the possibility of starting earlier. So that is within the plans. And it will be more of a challenge to deliver, but that's something that we've got to do. There is, of course, the possibility, I hope it doesn't happen, but it could happen, of needing to do additional vaccination even beyond 50. And we have asked and we have prepared surge planning for bringing further vaccinators in, because there could be another variant, a nastier variant that came on, and we might need to vaccinate the entire population again. So we need to be prepared for that. I think it's unlikely, but we need to be ready for that eventuality. So working from 50 is one of those things which comes into the plans. If I can perhaps pass over to Louise for the second question.
Yeah, absolutely, and clearly, Anne, we're very keen to ensure that we do get that place-based requirement that we've been working towards. So we've identified 53 clinical locations to try and cover a very broad ask, and that will be making sure that the bigger centre of population, so Inverness will have a vaccination centre in the middle of Inverness. We won't clearly have as many vaccination centres as when the GPs were doing it, because there were GP practices all over the place, but it's making sure that there's one within a reasonable distance for communities to go to. And certainly we've learned from the last programme about how we get up to speed with some of those. There was a bit of a lag with some of the areas that we needed them in last time. We won't be having that lag this time. We'll be ensuring that the clinics are up and running in a timely fashion. So yeah, we've got a clear understanding of the spread we need to cover the population, but it will be different to when the GPs were doing it by necessity. We have got a map with all of the areas in it so that we can share that too, in terms of giving people an understanding of where those clinical areas are.
Thanks, Louise. Sarah and then Jerry.
Thanks, Boyd. It wasn't a question, it was just a comment to say I fully support and endorse the options appraisal approach that we've taken, particularly for our island communities. And just to say that obviously you've said that kind of approach will continue, which I think is absolutely essential for us to be able to deliver a person-centred approach for those communities, and really just looking for some assurance that that continued and kind of future options appraisal will use, I guess, some of the methodology that we're seeing in the island impact assessment framework, or if that hasn't been done already. But just to say, I'm really, really supportive of that approach and really pleased that we've been able to do that for those communities. Thank you.
Just a quick word on that. Yes, I think we all welcome that. I mean, it's we are bound by national policy in terms of what we can do it, and we welcome flexibility where that has been allowed, and we've used flexibility as much as we can over the course of vaccination and trying to say that. For example, I think we were the first board to get permission to vaccinate entire communities rather than going age by age, because it just makes entire sense. So we've been we welcome the opportunity there, and we will use whatever options appraisal and flexibilities that we're able and allowed to use to maximise the benefit to our residents. And hope that will continue generally, both in terms of any option appraisal or and island equalities issues.
Jerry, followed by Garrett.
Excuse me. Thank you, Boyd. Probably a couple of questions. The first one potentially on the logistics of it. I'm presuming, Tim, that all communication with those being called in for vaccination will be from the board, because we ran into problems, I think, with the last programme in terms of people getting totally unrealistic letters. And following that up, therefore, does that mean using the 53 clinical locations in North Highland, for instance, that people have been notionally allocated to a clinical centre to receive their vaccine, or will they be presented a choice? And maybe my final question on this, a sort of a tangential one. In our planning, Louise, for North Highland, for the childhood vaccinations, have we been able to make any inroads into addressing the issue I think we spoke about at the committee a while ago, in terms of the amount of time of school nursing time that is taken up in delivering the vaccine programme, which I think was circa 63-64%. Thank you.
Thanks. If I take the first question, everybody we're aware we've had the difficulties in terms of communication. Part of that is trying to harmonise the individual approach that we've had with the national approach. There are benefits from the national approach, and for example, getting blue envelopes, and people take them more seriously than getting letters just from the board. I mean, and I think there's a cultural element to that. What we will be seeking to do is to try and make the best of bringing the two systems together. I think that there have been some ways in which the local and the national systems haven't gelled together. Let's say in time scales of how long it takes to get appointments booked, where appointments are available, the numbers of options that are available for people. We've learned a lot of lessons. So I anticipate that the vaccination invitations will come centrally, but and they have my name on them, but they will be there will be then local flexibility to and a lot more workable local flexibility to allow people to choose the vaccinations. And I think the way of, it's not wouldn't be quite allocation to local places as saying you're going to have a vaccination in a certain place, but that may be a preferred option, but then people would be able to choose and rearrange their vaccinations because they may be at work somewhere, and that may not be the most appropriate point for them. So I think we're confident that we'll have a better system. I can't give an absolute guarantee that we won't have problems and there won't be some hitches along the way, because we're still refining the process, but it's an awful lot better than it has been. Can I pass over to Louise?
Thanks. And yeah, just to add, in relation to the letters, there was the test run of the lettering for Argyll and Bute last week. There's a test run for the lettering for Highland next week, and that is just to ensure that any glitches we had last time are ironed out with the increased locations that we put in, etc. So there is that prep work this time to really make sure that we're in the better place with that. So that's on the lettering front. But in relation to the school nursing, absolutely, we're still having a dialogue with the Highland Council around that. Ultimately, yes, we will be moving all of those vaccine over to ourselves. We've got to understand what that means in terms of workload and costs around that. We anticipate, when we've looked at it, we think that it's about 5 whole-time equivalents that will be doing that work. It's just working out exactly the background detail.
Okay, thanks, Louise. Garrett.
Yeah, it's just on the same vein. It's just in my area in Argyll and Bute, when you get sort of as the crow flies centre, we have locks in the way. So you get a few people saying, "Oh, you know, I've been sent to Port of Addy or what have you." It's just I don't know if your systems can be tweaked. That was just the point.
No, thanks. I can assure you that there has been a lot of dialogue and a lot of discussion with Scottish Government around Argyll and Bute, the locks, use of Google Maps, and a range of issues. I think there was a particular issue a few months ago around people being sent to places that were too distant for them, and that we recognise that it wasn't principally a mapping issue; it was another issue to do with the software systems. But we certainly wish that hadn't happened. We apologise for that. We reissued the appointments, and the issues, particularly with Argyll and Bute, and the minimum number of vaccination points that we need is really clear. We want to stick to that, and we insist on sticking to that in order to give the best service to our residents. And we believe that is recognised centrally now.
Okay, thanks, Tim. We're being asked to approve the strategic direction for vaccination in Tim's report, and to take moderate assurance from this report rather than the limited assurance we took from the previous report. Are we content to do so, given all the points that have been made by Tim? Thank you. Okay, we'll now have a 15-minute break. We're running quite a bit over time, so can I suggest we reconvene, give you a generous 15 minutes to 11:30?